So looking forward to connect. Before I hand over to Joanna, I just want to say Joanna is a fantastic psychologist working at BJ Wadia Children's Hospital. And she's someone who can teach even those of us who are practicing pediatric palliative care every day. So I'm very glad to share the platform with her. Joanna, anything else you want to add about yourself?
I don't think I could beat that. That's such a flattering description of me. But I'm really hoping that the next 2 hours will be interactive and that there'll be sharing and learning, both for us and for you. So thank you so much. I just wanted to add that I work in a children's hospital part-time. It's called Baijar Bhai Wadia Hospital. Some of you might know it. It's in Bombay, and I do have private practice on the other 3 days. And I'm so happy to be here with you. Thank you, Dr. Spandana.
Thank you, Joanna. Before I share my slides and before we go further into the session, I think I'm learning to acknowledge that these sessions, no one is making you attend them. And this is your family time, your rest time after a very busy day. And you're giving this time to learn something or to interact and further discuss things. So thank you so much for your commitment to help children that you care for. I really want to start by saying that. So thank you. It's a privilege to share this space with you. So I think one thing we are talking today about is communication with a focus on speaking to the adults in the family when we are taking care of children with serious illnesses, and that includes cancer, but also non-cancer. Uh, as we go forward, please feel free to ask your questions in the chat at any given point of time. Joanna will keep an eye on chat when I'm presenting, and I'll do the same for Joanna. And but also, I think we will have enough time to unmute and speak with each other, interact. I think both of us want to have a dialogue rather than us sharing what we know and leaving, but rather than we would love to hear about your experiences. In the next few minutes, both of us want to cover about understanding the importance and what are the various components of effective communication, especially in the context of palliative care, but also I think it applies to oncology. And also thinking about what research tells us about what is important for families. Over a period of time, there has been a lot of research generated, and we will look at some of the aspects. And then, if possible, let's try some of the tools that we will discuss today, which is both spikes for breaking bad news. And there is a framework called Wish, Worry, Wonder framework, and we can talk about it a little more. Just thinking about communication, I think a lot of times, and especially me, earlier in my career, I always thought good communication is when I gave a lot of information to the families. I went into the conversation and I shared a lot of things. But over a period of time, I realized that it's a two-way conversation. It's not just me as the doctor sitting in the conversation and giving whatever I know, but rather listening to what they need to know, but also what they understand and answering their questions. So, with communication training, it became much more clear that communication is about sharing ideas and feelings. And the aim of the whole thing is to reach an understanding. And when we talk about palliative care in the next few weeks, as you attend more and more sessions, you will keep hearing this thing: family-centered care, family-centered treatments, and family-centered communication. So, what is family-centered communication and why are we talking about it? Is mainly to understand what family members know about their child's illness. So it's not just our understanding or what we communicated, but how much have they retained and how much have they processed, and thinking about how do we explore the impact of this illness. And in most of your case, your participants' case, it is a cancer. So what is the impact of this diagnosis on the child, but also on the family's well-being? And then a lot of the times we have a lot of paths that they have to choose between. And it would help us to understand their preferences and priorities of care before we can even present them with these options. And also, this family-centered communication focuses on understanding the family's previous illness experiences. Oh, I wanted to ask this question. I forgot and clicked next, but this is the thing. So it's a very old research. If anything, I'm sure the time has decreased, but not increased. So they have done a study through video monitoring. And when a patient comes into, but this is in adult, not pediatrics. So when the adult patient entered a room, and this is not also in the context of palliative care, but in general medicine, people have gone to the doctor and they have started speaking. And within 11 seconds after the patient started speaking, the patient was interrupted. Imagine 11 seconds. But for us who is hearing from the patient, it might sound and feel like it's a long time. But for the patient in 11 seconds, what is it that they start? What is it that they can give us? So, what they have been trying to say, and probably 1984 is when some of us haven't even been born, right? So, this has been going on for quite some time, that we have to focus on allowing silence. We have to practice being silent sometimes and letting patients do the talking so that the most important things they have come to the consult for are expressed. So when we talk about different types of communication, there is verbal, there is non-verbal communication, there is paraverbal, and what our environment is communicating. So we have to be very, very mindful when we are speaking. And when we talk in this session, because this is mostly virtual, we might not focus a lot more on the rest of them, but you just have to know the science behind it, and it's very interesting. So in personal communication, this has been studied. Uh, Verbal communication, the spoken words, have a weight of 7%, whereas the voice and tone that we use to communicate is close to 40%. And more than that, 55% is the body language. So the way we sit, the way we hold ourselves, the way we place our hands, our head, our back, everything is communicating something to the patient and their family. So it's very, very important to think about all these things. And when I say body language, look at this picture. There is a picture A, there is a picture B. And a lot of us do picture B because when we go for bedside rounds, we want to finish the work faster. We do have a lot of patients. So that could be one of the reasons that would come to your mind for why we stand, finish talking, and move on to the next patient. But can you see the impact of body language in these pictures? How is the patient, how is the family member looking at the doctor? And because all of us come work with children here, imagine like for a child, it's much worse, right? Even when they're standing, they are like adults sitting. So, how do we start thinking about being more aware of our body language during the rounds, during the concert? I think these are some things we can talk about going forward. So this is a very, very interesting quote. The single biggest problem in communication is the illusion that it has taken place. So the people who have spoken to each other believe that they have communicated, they have transmitted the information, or they have gotten the understanding of the other person. But when it goes to actions, it might be clear that they haven't received the communication as we have intended, right? And this is not just true for the children and their family members, but sometimes even within our team, it happens on a day-to-day basis. We think that, oh, but I have told you this. And they say, no, this is what I have thought. And there is this gap between communication. So again, thinking about how do we bridge that gap? How do we make it as shorter, as smaller as possible, the gap, in thinking that we have communicated and they have understood. In reality, that they actually understand what we have said and they communicate it back to us. So thinking about the core skills in communication, one important thing is active listening. The second thing is responding with empathy. The third thing is the power of silence and using it in our conversations. Just thinking about active listening, I think it's very, very difficult in professional spaces compared to personal spaces because the way we have been trained in India, but also in a lot of places around the world, is the doctor's job is to do one, two, three. And usually that does not include listening to the patient itself. So again, active listening is something I had to practice and I had to recognize that it is a skill, and only then I can incorporate it within my communication. And what does active listening mean? Letting the other person speak, interrupt only when there is a need, encouraging the person to talk, listen for any hidden questions they're asking us, and allowing for short periods of silence, right? Along with this, it's equally important to maintain eye contact because if I'm looking at my mobile phone and I'm nodding my head, that is not active listening. So, eye contact, nodding the head, the body language, I think that also indicates active listening. And when I said listen for hidden questions, we might ask clarifying questions, and that indicates to them that we have been listening. For example, we might say something like, uh, sorry to interrupt, but I think I thought you said 4 months ago you went to this hospital and took this treatment. Am I hearing you right? And the patient might say, no, 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 that was 3 months ago. 4 months ago, this is what happened. So asking that clarifying question also indicates to the patient and the family that we have been paying attention to them. And this is very important to uh, to begin effectively communicating with the patient and families. And then thinking about empathy, again, I think the difference between sympathy, empathy, and compassion is being discussed quite a bit in communication now. Sympathy is feeling sad for someone. Someone is going through something, and you're saying, oh, this is so sad. Whereas empathy is imagining ourselves in their position. And even though a lot of us are empathetic, most of us are, it doesn't translate into communicating with them. So here are a few sentences that can communicate that empathy. I can imagine this news must be a shock for you. I wish the situation were different. I wish I had better news. So these are sentences which say that it is difficult for you, and we see that. And Joanna is going to tell you a few more ways of using empathy statements. But some of you might say that if we are really nice people, do we have to hide behind these sentences? I think what I would say is, even though in general we are nice people, we are busy people, even though we are empathetic, we understand families are going through a difficult time. Sometimes we forget using the language to say that we see you, we hear you, and these empathy statements make that difference. And then silence. I think this is the most difficult thing. Even in our fellowship, we always find this is the most difficult one that they pick is silence, because we are trained to never be silent. Even in our Viva exams, practical exams, when they ask a question, even the examiners expect us to answer immediately. I think the same thing happens when patients ask us questions or say something, we respond immediately. So, but silence has a lot of power in allowing space for the person to process their feelings and thoughts, and for them to think a little more. And if they don't speak after a short period of silence, and you can count in your head 1, 2, 3, and if the person hasn't spoken after 15, 20 seconds, you can start speaking. But I think this is something, again, you can observe tomorrow when you go back to your clinical practice. Do I allow silence in the conversations? So here is a question for you all. I will try using Menti, but if it doesn't work, you can use the chat or unmute. During the disease trajectory of the children you're caring for, are there specific stages that come to your mind where we need excellent communication skills? Let me just go back, try and... Oh, interesting. It doesn't allow me to do both at the same time, like share and 1 second. Thank you for your patience. I'm really learning here. And I appreciate it. Yes, I can see it. Let me just... Can you see it, Joanna?
Yes, I can see it, and I can also see that some of you are putting some of your answers on the chat.
Oh,
That's
they
great.
did? Okay,
Yeah,
fantastic.
a few of you. That's great.
Yeah. If you're able to, please feel free to use scan the QR code or go to menti.com and enter the code, and then we will be able to see the answers you're putting into. Oh, why don't I see the answers now? I should be able to, shouldn't I? I think most of you did get it. Let me just see what's happening on my Menti. Yes, I see the answers, but you can't see them. I see. Yes, I see unexpected complications. You think we need excellent communication skills, refractory disease, a diagnosis, acute deterioration. It's fantastic. You already know all this, so can you see, Joanna, what they have said? Because after this, I'm going to hand it over to you. Joanna, is this visible?
Yes, sorry, Dr. Spandana. Yeah, I can. This is visible, and I can also see that somebody has to leave because of an emergency. Urmila has left, and I think your responses on chat are also sort of aligned
Similar?
with what. Yeah, great. Dr. Spandana,
Rizwana,
can I request
Joanna,
you to
yeah.
change the slides for me, please? We'll
Oh,
keep that
okay.
presentation if that's okay.
Yes, no problem. I'll do that.
Thank you.
Can you see, Joanna?
Yes, absolutely. And I think this I'd like to begin really by summarizing some of what you have said in the chat messages. You talk about at the time of diagnosis, or you've talked about time of relapse, where or at times of when a child has ended up in an ICU or unexpected circumstances. So really, the slide is a summary of what you've already said. We need to communicate at various times of the illness trajectory, starting from at the time of diagnosis. And I love the fact, Dr. Spandana, about how you talked about the importance of communicating with children as well. And remember, when children and parents and families come to you, children are very disenfranchised and they anyway don't feel equals. So there is more the importance of at diagnosis communicating with the parents, but also with the child. And as you see on this chart, there are several sort of points at which communication is really, really essential, starting from diagnosis to the initial treatment. What are some of the decisions as a family they've taken? Some families have come to you from outside of the city, what are some of the things that they have to take care of? Some might ask for a second opinion. So I think it's in all of these, it's at this transition point as well, where you have these conversations, where you communicate with families. Once you've made these sort of early decisions and you've started treatment, you have stages, and sometimes there is a stable period, and then there are sudden unexpected changes, as you've kind of talked about in the chat. It could be where the child has had to go into the ICU, or has developed severe side effects and is really miserable, and the family who were already, who you thought were prepared for the journey is are suddenly falling apart, or doubting what they're doing. So I think this is another important time of when we need to communicate. Then again, as you probably already do, when there is a change in the prognosis, when you've kind of gone from a very stable period to when things are declining, or there's sudden complication, that's again another time when effective communication is really important for families. And then when the illness trajectory shifts from being purely curative to then actually palliative, where you're looking at of goals, like how do you make the most of whatever time a child has. We then look at focusing on comfort care, and this is a huge sort of it's a very difficult area where communication can really help families, but also clinicians. So as doctors, if I were to ask you, how many of you have discomfort in this area, is there a way to put a show of hands to say, I have discomfort in sort of when the goals shift? Any of us have that? Is there a way to do that, Dr. Swandana? Not really, is there?
Sorry?
But yeah, no. So I think I was asking if there's a way to kind of people to put their hands up to say if they've experienced discomfort in this, this sort of
Yes,
when the
they
illness
can.
trajectory. Yes, lovely.
Yeah, I see a few hands up.
Yeah, and it is really equally important that the clinician communicates effectively with families, and then again, as you go along the trajectory to a point when the child is at the end of life, and this again is hugely difficult, not just for the family but also clinicians, because you've had attachments with the child and the family, and you're still having to sort of communicate, and there are feelings that you're also having to deal with yourselves. And then once the child has passed away, there's communication around bereavement, and I don't know how many of you have those opportunities, but you often have families that may come back to you a year or two after to talk about what's happened. So there are those opportunities of communicating for after a bereavement. So again, I think to summarize it, what are the important aspects along this trajectory is to build trust and explain, to support and guide, and you adapt and reassess. When the trajectory has changed, you reassess where the family is at and what options they have. You discuss and align with that, and guide and be present. And I think through the follow-up and care after, communicate effectively. So this is really the various points at which we can summarize where you as a clinician would have opportunities to communicate. If I could go to the next slide, please, Dr. Spandana. So what does research tell us about what is important for families and communication? Now, some of the research that has been done indicates that families want to know the facts. When facts are provided in a clear and understandable format, even if the information is hard for the family to hear, they still want to know the truth. And as we go along, we'll probably talk about how that's done. Other research has talked about how families want honesty and empathy. And again, we'll elaborate on this. Families also would like to be, you to respond to concerns and emotions. If they have concerns about their treatment or what's going to happen. They also would like to discuss what can be done and to set realistic goals, and to include parents in decision making. Now, that's a very important one, where parents are given the choice to sort of make to be stakeholders in the decision making process. So this is what research tells us. And if we can move to the next slide, please. Okay, now this is so we're going to, in today's session, introduce you to two frameworks. Now, I truly believe that all of us have our own unique styles of communicating. And we bring to this framework a bit of ourselves and the essence of who we are. And so I'd like you to keep your minds open to this framework and the other one that Dr. Spandana will share. So now this is a framework that talks us through how do we break bad news. Now, the protocol the framework we're talking about is called SPIKES. If you can go to the next slide, please. Yeah, so SPIKES is an acronym for breaking bad news. Now, is the setting. So where do you have these conversations? Where are these conversations most receptive? And what's sort of, where is it fair to have these conversations? P stands for perception. What do families understand of what is going on? What do children understand of what's going on with regards to the illness and the treatment? Invitation, again, is I, where you where you're asking permission for for parents to let you tell them about the child's illness or the treatment. Knowledge, which is K of SPIKES, which is, what is the information that you can provide them, which is without jargon, which is simple, which is accurate and true. And again, E stands for emotion and S for summary. Now, we'll talk about each of these in detail. If I can go to the next slide. So when we talk about setting, I don't know about your setups. You probably are from varied hospital clinical setups. But if you're working in a government setup, or if you're in a government hospital, or in a hospital like mine, where space is at a premium, and you'll have a busy OPD space where there are several people overhearing. So it might be worth thinking about or creating a space where you can have privacy. A quiet space which you can book for some time, or if you have a cabin, that's great, where you can, or a teaching room where you can move to, where you have the the ability to have these conversations. Make sure that there are no interruptions. It might be keeping your phone on silent, making sure that your department knows that you're having this conversation with the family. And before you have this conversation, you kind of, or with the family and the child, you review all the notes and have all the information that you need before you. Especially, I think one of the key things is to try and remember the name of the child, and if possible, the parents, and just a little bit, so that they feel less uncomfortable about being in that room with all of their fears about what you're going to tell them. It's helpful to involve others, other family members, or other healthcare teams. If you have a nurse, or if you have a counselor, or if another member of the healthcare team, that will sort of add continuity to the care that you're providing. It's important to sit down, and Dr. Spandana has already talked about body language and about the manner in which we sit. And people, often never, ever forget about how they are treated in these initial or throughout their journey and throughout their vulnerability. It's how attentive you are, how you sit down, how you, allow people to introduce themselves and allow enough time. I think this is such a key thing. And Dr. Spandana is going to talk about how do you build an effective therapeutic relationship. And I truly believe whether it's in my own experience of working as a therapist or working in a hospital setup with the oncologist and patients, that initial rapport and that trust that you build goes a long, long way. And so it's really worth investing in that and allowing for a setting, a space that allows you to be free of other sort of worries and focus on your client, on your patient and family. And I move on to the next P of the acronym, which is perception. So it's always, it's always useful to get information from the family before you give information. So you might have a family that have gone to various doctors, and yours is the only tertiary setup. They've come to a specialist hospital. It might be worth just asking them, what have the doctors told you about your son's or daughter's condition? What do you understand? And that's actually, you're allowing for them to let you know what they get without feeling sort of intimidated. It's also helpful, to ask, what is your understanding of why your child is sick? And they will really take you through maybe the first time this happened, to actually what they've come to realize over all of the other appointments that they have before they reached you. So it gives you a real idea of their journey as well as where they're at. So then you know where to pitch your sort of conversation with them in how you're talking to them about their child's illness. The next slide will talk about K, which is the next acronym. Sorry, it's for I, the invitation. Like I mentioned before, it's often very helpful to ask parents, this about if it's okay for you to tell them more. You can start by using statements like this. Can I tell you more about what is happening? And how much information about what is likely to happen would you like to hear from me? Now, you're giving parents the choice of how much information they would like, and you're also being mindful of the pace at which they would like this information from you. And often when we rush through information, we realize once you've given them the diagnosis for a while after that, they're probably in shock and not able to register a lot of what you're saying. So it's helpful to sort of ask them for permission before you give information, and give them the choice, if possible, about how much they'd like and what pace they'd like you to go. The next one is K, which is knowledge. It's useful to have all the facts ready to kind of do your prep before you go. Just maybe quickly browse through. I know you probably have very busy OPD setups and several patients to see, but just a quick glance to a summary or a genogram that will help you, and the summary of what's been going on. Have all the facts ready, the reports, so you're not having to ask for reports midway or having to call a nurse and chase up reports. It's preferable to have it all with you before you start this conversation. And you give a warning shot to give a warning before giving any bad news. And it's often a very hard thing to say, because sometimes as doctors, as clinicians, we want to sort of keep a brave face and be very optimistic. But it's okay sometimes to say, unfortunately, I have some bad news. And what that does is allows families to sort of shift gear. So they're probably sitting there wondering what you're going to tell them. They probably, it then aligns them with what you're going to tell them. So they know that something's, there's something wrong, that this news is going to be difficult. It helps them brace themselves for it. You avoid medical jargon. Doctors sometimes use words that not everyone understands. And it's wonderful to say, please stop me if I'm doing this where I'm using words that you don't understand. Dr. Spandana, is my network okay, and can you hear me?
Lost you like for a few seconds, so it's not changing what we hear, but we are missing few words.
Okay. So again, I want to give you an example of this. We were sitting in a counseling session of a child who deteriorated quite suddenly, had low platelets, and actually ended up needing the CPR. And we were having this discussion with the family, and the doctor I was with was using these, really was explaining to them in medical terminology. And after all of the conversation, the father stood up and said, yeah, why don't you give them the, platinum de do? So he used the word platinum, and I didn't understand what that was about. And then actually it was platelet that he was talking about. And I think we'd had to sort of unravel a lot of the other terminology that the doctor had been using. And it's really helpful to sort of really simplify the information that we're giving them, because whilst it might be really obvious to those in the medical fraternity, it's all new to the family. And again, give information in small pieces and check that they're understanding you accurately and frequently. So that's the knowledge part. If I can move to the next slide, please. Now, we talked about empathy and emotion. That's the E in this framework. Now, how do you express empathy? You stop talking and listen and observe for the emotion. You encourage family members to share how they're feeling, allow for the expression of emotion. A useful phrase to show families that you've connected with their emotion is, I can imagine that this news must be a shock to you. And that you're actually identifying, you're naming, and you're validating it. Another way to talk about express your empathy would be a statement such as, I wish the situation was different. I wish I had better news. So, I think that again, these statements are further enhancing your relationship with your, therapeutic, or your relationship with your client, where you're empathizing with them, and you're talking about how you wish that you had better news. So these are statements that you can to express empathy and emotion. Moving on to the next slide, there is another sort of a mnemonic for expressing empathy, which is nurse. It's really helpful to have these mnemonics because it helps you to actually, this framework here helps you get out of some tricky situations as well. So if you, one of the techniques here is naming. Now, this is a useful technique because it also helps you clarify. So if for example, you said, sounds like you're really worried about your child ending up in ICU, or that the treatment not having given the results that you were hoping for, it might actually give them the opportunity. Once you've named it, it gives them the opportunity to either agree or to clarify. So another statement would be, I wonder if you're feeling angry. Now, often these are people who probably have expressed or not expressed things. And when you name, you allow for permission to help them express and also clarify. Understanding, again, is the U of the nurse mnemonic. If I understand what you're saying, you're worried about how your treatment will affect your work. This has been extremely difficult for you. Now, again, in what Dr. Spandana talked about active listening, this is an important part of that. It's all connected, where you are you're validating and you're actually acknowledging that this must be extremely difficult for you. Respect and respecting is another technique. You can make statements such as, this must be a tremendous amount to deal with. Or you can tell a mom or a dad, I'm really impressed with how you've handled the treatment so far. Now, you see what you're doing in this is you're acknowledging them, because these are families. And I work in a hospital where coming to for an admission means losing your daily wages, or it means that there is a sibling in the house who's being neglected. There's huge caregiver burden, there's financial pressures. When you say, I'm really impressed with how well you've handled the treatment, you're actually acknowledging all of the small, all of the things that they've put up until this stage. The S in the mnemonic is for supporting. I think it's really useful for families to hear from you that you will be there with them through this treatment. And please let me know what I can do to help you. What is it that I can do? And sometimes they might tell you some of their problems that really are sort of causing them grief or coming in the way of compliance, maybe. And you might be able to put them in touch with your multidisciplinary team that could help navigate this. And again, E stands for exploring. So tell me, you explore a little bit more. So tell me about your concern about how the treatment side effects. Sometimes it's also helpful to ask, what do you anticipate will be the most difficult thing during his treatment? Or you can say, you mentioned, sorry, I can't see this.
Do you want me to read it?
I get it now. Yeah. exploring. Yeah, you mentioned that you're afraid about how your children will take the news. Can you tell me a little more about this? And this might be a time where you have an older child who, you at some stage you're going to have to tell them what they're dealing with, or it could also be, where this is for an adult who is ill, and the children have to hear the news. So when you ask a question like this, you open up avenues for them to tell you what their worries are, because sometimes you can go through conversations where you've had this excellent way of talking to families, and they come back in about maybe 2 or 3 days, and they're back to actually, what does this mean for us? Because they haven't understood, because they're, perhaps they've not been able. One of the blocks are that they've not, they're worried about finances, or they're worried about where they'll be, whether they're their family situation, or so those blocks are already sort of preventing them from understanding a lot of what you're telling them. So it's really helpful to ask them what their concerns are. Once you know what they're worried about, you can reassure them. Remember, otherwise they're probably assuming the worst case scenario, and when people are anxious and vulnerable, that's what our mind does. So next slide, please. So again, this is the S of the Spikes framework is summary and strategy. I just need to move this out. Sorry. I can't see his screen. Hold on. I'm sorry about that. I think I've done something and escape. Sorry, Dr. Spandana, I can't see my screen. Yeah. Okay, yeah, I'll probably read it off the other one I have, sorry. Again, it's summary and strategy. So you're really summing up what you've discussed so far with the families, the options where you're at, and you're summarizing. You check the overall understanding. Do you have any questions for me? And I keep getting this low bandwidth network setting, Dr. Spandana, but I am still audible, right?
Yes, you are.
Keep getting a low network. My network's poor, but you can hear me.
Yes, but I think we are losing few words from you in between.
Yeah, I'm so sorry. So again, you check the overall understanding. Do you have any questions for me? You review the plan for the next steps. So you kind of, we've had this discussion. So we kind of talk about, okay, if you're offering them this chemotherapy, this is how it's going to be. If it's going to be admit chemo, if it's going to be outpatient. So you kind of go through those details. And the most important thing is documenting these discussions in the file, because sometimes as a consultant, you might have spoken to the family. They're going to come back the next time and it'll be another doctor, another resident, another person. So it's, or you might have forgotten what you've actually other patients. So it's really important to document what's been discussed. Sorry, Vanilla.
Sorry, ma'am, if you can turn off your video and speak so that there's no lag, if possible.
Yes, I'll do that. Is it very bad? Okay.
Yeah.
Great. Okay. I'll just move on to the next slide. Is this better, Vanilla?
Much better, ma'am.
Fantastic. Okay, I'm going to just, in the next slide, Dr. Spandana, the last one is where we summarize the Spikes framework. If we could please move. Yes, fantastic. So just summarizing, Spikes is SPIKES, setting. You plan ahead and establish the environment. You use statements like, I'd like to meet with you to talk about what is happening with your child's illness and what might be ahead. Would that be okay? Now, these are some of these statements that, useful statements for you to use. Perception, where you're checking to explore what they already know. Some of the statements we've discussed, and just to summarize, tell me what you understand about your child's illness. What have the other doctors told you about your illness? I is the invitation, where you have information sharing and preferences. Would it be okay, like we talked about, would it be okay for me to discuss what we've learned from the medical tests? How would you prefer to discuss medical information in your family? Some people prefer the big picture of what is happening, and others like smaller details. So, in all of this, you're offering families options to decide the pace at which you can go, which is effective for their understanding. Knowledge, again, you give information. And like we said, use warning shots if there's something difficult that you want to talk about. I have something serious that we need to discuss. Or you can use statements such as, I'm sorry to say that I have some bad news. You say it simply and stop. You could say, for example, the tumor has grown and the cancer is getting worse despite our best efforts or treatments. And E, which is empathy, respond to emotion. And like Dr. Spandana has already mentioned, you use silence. I know this is not what you expected to hear today. This must be very difficult. So you are allowing for silence, and then you're using statements that allow for that and to normalize it, and to have, to validate what they're feeling. I'm sorry again about my network, but I hope that this, that I've been able to communicate a little bit about the Spikes framework. I can hand it over to you, Dr. Spandana, for the next part.
Joanna, do you want to finish
Oh,
this?
yes. Okay, yeah, sorry. One of the problems I'm having is I've somehow minimized this, but so okay, here we have. Now I'd like you to use the chat box perhaps to answer this. Now this is a case of a young girl, a 13-year-old girl, Reshma, who has presented with pain in the left lower leg following a trivial trauma 3 months ago. She's been to multiple doctors with
Joanna, your voice is
finally got a
breaking.
biopsy done, which shows again. Okay, Dr. Spandana, would you mind doing it?
No problem. I will read it out, but I'm sure all of them can see it too. So Joanna brought this
they
case.
get this from clearly, since obviously my network's poor.
Yeah. We can't hear you very well, so I will read it out. So here is a 13-year-old girl, Reshma, and had trivial trauma, went to multiple doctors. Same story that we have seen many times for Ewing sarcoma. And when the biopsy came back, it came back as Ewing sarcoma. Initially, there are lung mets, and she came to your cancer hospital, cancer ward with the reports. Family is in the waiting area. She's a smart child who can use mobile phone. She has a 16-year-old sibling. All of them are waiting anxiously. The father takes the file from Reshma, asks her not to worry, and says, everything is fine. You don't have to worry. And this is quite a common scenario that all of us see. So I think what Joanna is trying to ask through this scenario is, when you see all this happen, if not immediately, in the long run, what is our response? What should we do? How will we manage it? What are some of the challenges you see in your practice? I think we have spoken for quite a bit. I think we can use this time to interact with each other. Joanna, you can try and speak. If not,
Yes.
I can do.
I just wanted to add that, this is just an exercise to think about what are the challenges, or who do you think needs to be communicated with. So in this scenario, you've got the family there. Who do you needs to be communicated with, and what are some of the challenges that you might experience in the communication? If you could just type it in your chat box, please.
So, Joanna, I see one response. Discuss with the parents and the child. If anyone wants to unmute, please feel free to unmute and speak. Adolescent child will need separate counseling, is what one of them says. Parents first, then the child. I think most of them believe that it's better to have the conversation first with family and then the child. Yeah. Anupa
Fantastic.
makes the point that information can be misunderstood. Sorry, if you can see Joanna, you can go ahead. Like I'm reading it out because I wasn't sure if you can still see your screen.
That was great.
So
I just, this is great. You carry on.
I like one of them. Most of them have said the same thing, but I think few other things they have said is probably do the communication in a staged manner. Make sure the child's misunderstandings are addressed, and then also to involve sibling is something one of them brought up.
That's fantastic, actually. That's such a important thing, really, because they're the most sort of neglected.
Yeah, I think. Joanna, do you want to say anything? Are you able to?
Yeah, I think Dr. Amit has talked about parents first time make small talk with the child. I think what Dr. Amit's probably talking
We are losing you, Joanna.
about is a little bit more, and it's really sorry. Yes.
Sorry, unable to hear most of what you have said just now. But in the meanwhile, let me just ask Anupa to share because I see her raise her hand. Please, Anupa, go ahead.
Yeah, thank you very much for the opportunity. It was a wonderful lecture so far, and I think it addresses a lot of concerns. One thing that I routinely face, especially when we're dealing with adolescents and preteens and sarcomas, is parents trying to not give them the information in order to protect them. But it is very difficult to let them know after, like, of course, we counsel the the parents separately. But it has been very difficult to convince them about breaking the information to the child, especially in today's digital day and age, when it is very likely, since they're going to be restricted to the bed, they're very likely to use the mobile phone even more. And then all these kids are very, very smart to sort of have picked up information. We have had cases where what haunts me is one of the cases where the child did have a metastatic disease, but was taking treatment, misinterpreted the information that he gathered from the Google and ended up committing suicide, honestly. So jumped off the hospital window where he was admitted. So I really try to tell the parents that it is best that the information comes from you, from us, from sources that can be really trusted. We have the scope to sort of measure, regulate the amount of information and the way it is presented. So yeah, I think that's a challenge, especially when I deal with sarcomas, because there's a lot of pre-adolescent, adolescent, and unfortunately they don't have a great prognosis either once they've metastasized. So yeah, something that I don't know if there are any other tricks and way in which the parents can be convinced better about sort of letting the child in the information. Also, I would want you to address, I don't know whether it's a part of this communication, this lecture, or would be covered later, is during treatment, a lot of children sort of isolate themselves because of hair loss, especially preteens and teens, and they do not want to interact with their peers and friends, even online, saying that they'll comment on my hair. And I always tell them that, would you sort of not talk to your friend if they lose hair? So trying to convince them, but that's also another area that I don't know how can we sort of not allow them to mingle with their peers even while they're undergoing treatment in whatever capacity possible.
I just wanted to say, Anupa, I'm so sorry to hear about the loss of your patient, and that must have been incredibly difficult. I missed a bit because I've changed my location. I'm now audible, I suppose. Yeah, I'm sorry about the first half. Yeah, great. So Anupa, your question was yes. So I've worked with a lot of adolescents, and this is a stage where appearances, peer approval is a big thing. And while sometimes we worry about them being socially connected, there are kids who will decide for themselves, this part of my life I want to keep private. I will connect with them once this is over. Some young people will connect through text, or they will have told a parent or a friend that, I'm going through a difficult time right now, and maybe share messages through text. But I think a lot of times young people decide how much they want to relate, or how much of what's going on they want to disclose to people, and that's okay. But if you're worried overtly about the social isolation, if you're feeling that they're really down, if you're feeling that it's affecting all areas of their functioning, that's something to worry about. So I wouldn't necessarily, and this is something I've learned over the years, because initially I went into this thinking, oh, they should be speaking to their friends, they should continue to have these. But I've had survivors come and said, no, Joanna, at that time I needed that space. I didn't want to go around explaining to everybody why I've lost my hair. So it's okay. I've kind of prepared myself, and it's mentally I'm geared for it. But I've also had people who have experienced bullying, who've lost friendships during this time, because and even now in India, even in places in Bombay, there's a lot of stigma around cancer, and I've had siblings who've not been allowed to eat off the same plate.
Thank you, Joanna. I absolutely understand that. It was not forced. It was something that the child shared. So that is something that the child shared, that I miss school. I mean, she was she was crying when I went for rounds, and a parent shared that she misses her friends. And I asked her, then why don't you talk to them? And they said, so this is what she came up with, that I'm scared, that they're not good to. And what also happens is that parents become overprotective and do not allow to sort of mingle them, even when we ask that it's safe. If your child is comfortable, please let them. But they become overprotective. So that's a difficult part of and I've seen the symptoms being exacerbated with social isolation, and also going down when the psychological aspect of it was addressed, especially in adolescence. So I totally understand that they have all the right to their privacy.
No. But and that's great. I totally get that. I missed bits of the conversation, but I wanted to say is, it's always helpful if the child is expressing something such as, I feel alone, or and that's something to listen to. There are certain strategies that we use as counselors to deal with this, where you get them to externalize the illness. And if I'll just give a very brief example. So if there's a technique where we talk about separating the child from the illness. So where you talk about, okay, what if you had to call your illness something, what would you call it? Sometimes people will call it Voldemort, or they'll call it a beast, or they'll call it a creature. And then you separate it and you talk about how has it affected your life? What has it done? Whereas they know then at the end of it that it's the illness and the circumstances that have led to the isolation. So I think it would be really helpful if you have access to a counselor to kind of tap into their expertise in this. But it's so wonderful that they feel comfortable to tell you about this, and that you are there to listen.
Thank you. Appreciate your input. Thank you so much.
Joanna, I just wanted to add one more thing. There is a framework, Anupa, which is called ARCHES framework, which I will type in the chat right now. So what you have said and what we discussed, it's called collusion, where the parents are colluding with us, healthcare professionals, to not reveal things to the child. So ARCHES framework is a great one to use to negotiate that space. So think of this as you going into a vegetable market and trying to buy stuff, right? They say 50 rupees. You say, nay, you have to give it for 30 rupees. And they say, no, 48 rupees. And then you say, okay, 35 rupees. So this is what ARCHES is, in fact. Like, you tell the parents in different ways why it is important for the child to know. And then they will say, no, you can't tell my child anything. And then you start negotiating. And the negotiation, again, there are many, like what you have said, children are very smart. your child, I see like during the rounds, the file is on the bed, they have a smartphone, anyone can Google metastasis. Do you think your child did not look at the reports? And most of the time say, no, 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 they are the ones carrying the reports. Then I say, does your child use smartphone? And they say, yes, everything. They know it better than me. Do you think your child did not Google like this? And a lot of the times that's when they come to the realization that the child must have read something. And I also say things like, when you say there is something in this hand, even if it is just air, if I say there is something in this hand, put your finger, you will hesitate, right? Like, what is in her hand? So not knowing something creates fear. I think I try to give those examples, and but not all parents agree, which is what we have to accept. But then there are some families who say, okay, I will be in the room and you can talk. And sometimes I say, I will not talk about cancer, I'll not talk about metastasis or anything. Instead, can I talk about, we call it wishes, worries, and hopes. So what is it that they are wishing for? What is the most worrying thing for them, and what the child hopes for? And that's it. That's the first conversation. And I think it demonstrates to the family that this doctor, especially because we did not have training before, is not a dangerous one and is not going to harm their child by giving them information suddenly. Right?
Thank you. That's very helpful. I'll definitely go through the framework. Thank you so much.
Yeah. So a lot of my Western colleagues, Western trained colleagues say that if a child, especially teenager, 13, 12, like tweens, ask for information, they have a right to the information, is what they strongly believe. So if a child point blank asks them, I'm 12, like they know they are 12, like, will I die? Do I have cancer? Am I going to die? They actually end up having that conversation. But we have to remember we are in a culture where parents are the boss, or like the patient is never the boss. So you have an adult 80-year-old patient, the son is telling you, 40-year-old son is telling you, you can't tell my father about his health condition, and we have to listen. So that's the kind of culture we come from, which is not a negative thing, because again, everything is being done in the name of love because they want to protect the person. So I see questions like, what if the parents say, don't say, I will not say. I will not say, nahi, मैं बोलूंगी, because when I say that, they will not come back to me and I will not be able to help the child, right? So we go ahead and follow the parents, but we will not give up on trying to tell the parent why it is important for them or us to have that conversation. Joanna, I think we should take few questions now before we go further, because we did speak for quite a bit, and it's important, I think, to clarify. I see there are a lot of questions. I will read the next question, Joanna. What would
Sure.
be the best opening statement or gestures while breaking? Is it okay if we don't go into the topic of children, because you have next week to deal with children specifically? You have other experts coming in. So, Srishti, I'm sorry, we will skip your question only because we want to do justice to the topic we are assigned, which is communicating with adults around children with serious illness. But please make sure you ask it next week. Thank you, Srishti. Uh, Lisa. Lisa has asked Joanna that does the course of this conversation, does it change? And should be changed when relatives start recording the conversation?
Yeah, that's a tough one, isn't it? When you know that they're recording. But you know what? I think that honesty really helps here. I would just ask, I mean, have you guys ever tried asking, I can see that you're recording. Is there something or someone out there that you feel I should be speaking to? And it might be that they're recording just because a decision maker is there in the village and they don't know, but that person knows. Or there's a doctor relative somewhere and they're recording for that. So it may not automatically mean that they doubt or they're suspicious of what you're telling them, or they want, or sometimes it might just be that I don't trust that I can retain all this information, so I'm going to record it. And in this day and age, we use our phone, we take photographs of any people and places around us without taking consent. So this become, the use of technology has also been abused a lot. So I think it really helps to say, it's okay to say, I can see, are you recording this? And what is it about what I'm saying, and who are you recording it for? Would it help if I spoke to that person directly? And you can say, in my hospital, we have a rule that we're not allowed to record. And any permission have to be coming with consent and all of that. So I'd be happy to talk to whoever else you are recording it for. I'll be giving you the summary so you can take it to another doctor elsewhere. So, when they know that you're not threatened by that, but you're actually looking past that act of recording into what could be going on for them, that they're recording, is one way of dealing with it.
Thank you, Joanna. And I think it is important to remember about the tone of the question we are going to ask, like, are you recording me? Like, may I know why you're recording me too? Like, why are you recording me kind of thing? Like, what Joanna is trying to say is being defensive is not going to help our cause here, because then they would naturally assume, thanks to the media and newspapers, that we have something to hide and that's why we are fighting it all, right? So I think that is what she's trying to say. The other things I do, Joanna, is I ask, would it help if I give you handouts, like printed handouts? And also Joanna spikes setting in S, the setting, asking them, do you want someone else in this conversation? What would be helpful for you to go? Because I have had parents who record voice because it helps them to remember things because they're not writing it down. But if that is not something you're comfortable with, you could always say, do you want like a paper and pen to write down the things I'm saying? Would that help? So just thinking about it, not in a negative way because of what's happening to the doctors too out there, but rather coming back with the humility to understand why they're doing what they're doing, I think is a very good way, Joanna. Thank you for that.
So yeah, I just wanted to add, I've had situations where in an ICU setup where they're already assuming there's some wrongdoing or there's some negligence, and that's when they record, and that's happened as well. But at that point in time, I think it's okay to say we have a hospital policy. I can see that you're recording. That whatever it is that you want, you can ask for reports. You can direct them to the medical superintendent or whatever else. So I've been in situations where it has been used as evidence for them to come back and say, look, there has been negligence, or you told me this and this is what's happened. So and it's okay at that time to you know that there's something going on there. So it's how you deal with it.
Yeah. Any other questions? We do have few slides left over, but that's okay. I just want to make sure like your questions are addressed before we go further. No questions? Language barrier. That's a tough one.
Yeah.
And I face that every day. And it's very difficult. And I think when you don't know the language, you become much more aware of the body language. So sometimes I'm in this conversation, everything is in Arabic, zero English going on, but I kind of understand what's happening because of the body language. I'm much more aware of it. And I assume it's the same for patients when they're focusing on us and they don't understand the language fully. So I think that's the only thing I have to say. Joanna, anything else?
I mean, sometimes I'll check around to see if anyone else speaks the language. So there might be a doctor in another unit, and I'd ask for help. It's if you can, or use if you have an interpreter, which is a luxury which we don't have.
Yeah. Interpreters are the best. Using others too sometimes when they're uncomfortable, especially with hard conversations, they don't tend to transmit it the same way. Yeah.
So
Agreed.
translators don't serve the purpose most. So it depends on the setups, and I think Dr. Amit, I think you're in the UK, right? So there they have translators, I think interpreters that are trained to do this. But you're in HCG Bangalore, yeah. You're right. They do require specific training about actually only translating what you are saying without adding 2 bits of their own sort of advice, or changing the context and adding on. So you're right. I look at a colleague who's probably speaks the language, or I get a lot of clients from Calcutta, and so I know somebody who speaks Calcutta or somebody who speaks Tamil, and I'll make time with them to say, could you please help me out here?
Yeah. I see a question from Smriti. How does one counsel the parents about the long course of the treatment and its implication on their livelihood? I wouldn't counsel about like the implication on their livelihood, because that would mean a lot of assumption on my part. But the first part, I think we can answer, like, how do we counsel parents about the long course of treatment? From a physician point of view, again, remembering what Joanna has said, like thinking about, I don't have good news for you. I'm sorry, what I have to say isn't something very good, or I'm afraid I have some bad news for you. Like, there are multiple ways to say it. To give a warning shot, I would start with that. Or I have difficult news for you, or I have some difficult information for you, because you're talking about the long course of treatment. So being very specific about the language. And once you say that, you need to give a little pause, because the family has to be ready for the difficult news. And then you say, I have some information for you, which might be difficult. Let me know which is the best way. And then you go ahead to explain what the treatment is. Ideally, if it is very long, I would use a paper and pen. And at the end of it, I would always ask, do you have any questions? That's a lot of information from me. Do you have any questions? And I would say, would it help to get a printout? Would it help to have a physical paper with you? And then listen to what their worries are and then address them. But again, Joanna, anything else you want to add to that?
No, I think in our hospital, we constantly get asked how much is it going to cost. And then, it's okay to be honest and say, this is how much it's going to cost. And then point them out to trusts or places that they can go to get some financial support. Yeah.
So if you have any questions, please post it on the chat. I will just go ahead and try and go through these slides. I have a few more Menti slides, which honestly I will not go into, because I don't think we have enough time. But yeah. So just so that we remember that a lot of the times, a lot of us assume that we are good communicators, right? And we say, and we like to give good news. And I'm sure it's all the more true with oncologists, because a lot of your work also involves giving bad news. So we will take the good whenever we get it. So if we are stating as a doctor, his labs are better today, the family is hearing from you, oh, he's getting well. He will get well. He's going to go to school tomorrow. So they're imagining all these things, even though all you're saying is his labs are better today. You're telling she's stable today. They're hearing she's getting better. And you're trying to introduce a concept. We have an experimental treatment, and the family is hearing this treatment will cure my child. I think this treatment is not working. Okay, this doctor is now giving up on us. He is dying. Do you want us to put him on a ventilator? Or even saying, it looks very bad. Do you want us to do everything? So the parent is going to think that you're going to do everything to make their child live long in a healthy way, right? So I think this is where the miscommunication happens. And then when the child dies, the parent is angry, and we are thinking, Arey, I told him he's going to die and I'm putting on ventilator. The father said yes, even though it cost 10 lakhs in 5 days, he asked me to put, and now he's ready to hit me. What went wrong? Because the father thought, sorry? Because the father thought spending this 10 lakhs in 5 days is going to make their child survive. But we meant, do you want us to do everything possible, even if it is like 0.00001% chance? But it hasn't been communicated. So how do we have these conversations is something I think we have to think more. A 1.5 hour session is not going to cover it. But there is one other framework that I find very helpful. I'm sure Joanna uses it in her conversations too. It's called Wish, Worry, Wonder. When you have to have a difficult conversation and the family is telling, no, 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 I wish like my child has to get better. And you want to say, I wish that things were different. I wish that was true. And I worry that it doesn't look like that. I wonder what we need to do if he isn't going to get better. Can we talk about it? So just thinking about it, it really helps to, instead of going directly to, no, the child is not going to get better, we should talk the next steps. It really helps the family to hear words like, I wish things are different for you, from us as healthcare professionals. And also us expressing hope sometimes, I hope that he will get better. And not but, because when you say but, everyone knows something negative is following. Instead, you say, and I worry that given what's happening, it doesn't look good, that he's going to get more sick. And I wonder if we can talk now about what to do if he doesn't get better. So this is a very good framework. It has, in difficult situations, it's always good. Again, as I said, we want to trade in hope. We want to give hope whenever possible to families. So when parents ask a direct question, point blank, is my child going to die? A lot of the times we don't expect that question, right? Like because we are having a conversation about something else. And we might end up saying, don't worry, I'm sure he will be fine. He's getting better. He has been stable. His tumor is not growing. So the answer is not, it's a possibility. Instead, we are saying focus on the good, ignore the bad. But it's better to avoid such kind of statements, which are giving a false hope to the family, while we know this child's metastasis is most likely to kill the child. So instead, it's better to say things like, we are trying all the treatments that we have. And again, instead of but, we can say, I'm worried that based on what we are seeing, he's, 1 second, sorry, my charge is done in the laptop. Yeah. And so we are trying all the treatments we have that may help him, but I'm worried that based on what we are seeing, he's not getting better. So you don't have to say, yes, your child is dying, but rather you can say what you're seeing, and you can say, but if the family insists, is my child going to die? Then we can say, based on my experience, it looks like that, or it looks quite bad. You could go back and answer. So going back to prognosis discussions, which of these are correct, you think? And you can put it on the chat. Discussions about prognosis are best held when it is clear a child is at the end of life. It should occur from the time of diagnosis. You shouldn't wait for the end. And discussion about prognosis can occur multiple times during the illness. I see people are posting multiple times. Some say, see. Fantastic. I don't know why they have scheduled a communication session for you, because your point on, like, it's perfect. Prognosis can be discussed multiple times, and it keeps changing sometimes in conditions. And we just have to be aware every time there is a shift to make sure the family knows what's happening and they see what we are seeing as trained healthcare professionals. So sometimes we say things like, you need to give this treatment, or we can leave the child, or we can stop everything else if you're not going to take this treatment. So, or sometimes we say things like, if you don't choose this treatment, you're choosing to let your child die. You did not come back last week when I asked you to come for chemotherapy, and because of you, your child will die. And I've heard this said multiple times in my experience. So again, thinking about things like whether especially when we are talking in the palliative care context, I think they need to understand that whether we go for a certain treatment or not, we will continue to care for your child, and we will do our best to keep your child comfortable. And one thing I think is the antithesis of what palliative care is. There is nothing more that we can do. I think since I've been trained in palliative care, since I have started practicing, I have avoided this word as much as possible. I don't say this, even when the child is dying. Even though one way to say this is, even though there is no cure, we are going to support you all through your journey. We are going to make sure your child is comfortable. But even internally within the team, we are always looking for what else can we do so that this child is comfortable. Again, just asking questions like, what do you want us to do? Do you want everything to be done? So things like that imply to the parent that there is like a menu of things that they can pick and choose. But instead saying that, knowing how sick your child is, what is the most important thing for you? I think that is very important. And a lot of the parents end up saying, I want my child to be comfortable. And especially in cancer, that might mean not going to the ICU. So using that information, we can further explore where the location of care should be, how much treatment we want this child to receive. And a difficult question, again, none of you have asked, probably all of you already do this. Don't give numbers when estimating prognosis. Sometimes families say, how much more time do we have, doctor? Or questions like that. Never say 3 months, 6 months, 45 days, 2 weeks, because we cannot predict it. And when we go wrong, families are more upset with it. So instead, we use an estimate, which is, it might, based on my experience, it looks like it might take hours to days. It looks like days to weeks, or it looks like weeks to months. And an estimate is always helpful, even for the family to prepare. So also to remember, again, we all have busy practices, but how do we connect with children and their families is making sure, especially with families, building that therapeutic relationship, therapeutic alliance, and showing the family that we care about the child, right? And things like, tell me what your child does at home. What makes her happy? What games does she like to play? Tell us about the school she goes to, her friends. Is she in contact with her friends? And you might think this is useless information for me to prescribe a chemotherapy. But if she is missing her school so much that she doesn't want to come to hospital, probably that could be the cause for treatment abandonment, where the child is refusing to come to the hospital. So knowing these small things, make sure that the parents trust you, but also improves the compliance of treatments. So 1 second. I think I will move on to this, but this is one question we can do. Which phrases are most effective when you're delivering bad news for a family whose cancer is increasing, especially prognosis? So tell me what you understand about your child's illness. I am going to tell you about your child's illness. Would it be okay for me to discuss what we have learned from the medical tests with you now? There is nothing more we can do to help your child. I'm sorry to say that I have some bad news. The tumor has grown. The cancer is getting worse despite your best treatments, our best treatments. Your child has a malignancy. It is likely metastatic. There are multiple statements that are correct, so you can choose few more. Yes, some of you are already choosing. Yes. A and C, fantastic. B, A, ACF. I'm going to show you the slides. So A, C, E, and F are correct. Instead of directly going and setting the agenda, I'm going to do this. Always try and say, is it okay if I do this? Never say there is nothing more to be done. Don't use a lot of medical jargon, malignancy, metastatic, and things like that. So just one thing, a lot of the people ask the question, if I give the prognosis that the child is not doing well, the family will lose trust in me. Why should I do that? So again, I don't want to go through this, but here is a paper that shows that they have done the breaking bad news. So they have given the parents information about prognosis, and they went and looked what happened to their hope. Before information, it's this much. After information, it's almost the same. So what they're trying to say is information in itself doesn't take away the hope of the families, but rather how we give that information is what impacts their hope. I think at the end of the session, Joanna and I would like to reinforce that communication skills are something we all can learn. There is no by birth good communicator or a bad communicator. Active listening, silence, empathy are very, very important in our practice. Spikes is a useful guide. Try and start using wish, worry, wonder, and see how it will gentle the impact of the bad news that we are giving the families. And also, as you all have said, don't forget the importance of involving children, the affected child, and the sibling in conversations. Any other questions that come up for you, especially communicating with adults? Joanna, do you want to say something?
Can I ask one question?
Go ahead, please.
Yeah, something that we often face again in practice is when there are multiple, it was mentioned that you invite other people to sort of become a part of the decision making, but what do you do when there is conflict within the others, sometimes between the parents themselves according, about what to do with the treatment, and sometimes there are young parents who are willing to take the treatment or are willing to go ahead with the suggestions, but the patriarchs or the adults in the family or sort of the community sort of advises against them. So how do we handle, is there anything that can help us handle this conflict better when we're trying to direct them towards the diagnosis and treatment?
Joanna, I will start because I'm sure you will have wiser comments to say to what I answer. Anupa, that's such a good question and such a tough one too, because this is not about us doing our job as doctors and giving the right treatment, making sure the child gets better. It's now about bringing families together. And sometimes, as Joanna has said, it's great to have a trained psychologist, counselor, but again, all of us don't have that benefit. So what I have done in the past as a doctor who was stuck in this situation is one, trying to bring them to the table together, giving an appointment, making sure all the parties are there. And sometimes they don't come in person, these patriarchs and whoever is trying to decide in the background. I try to get them on the phone and I try to address their most important worries. And I'm very open to whatever they say. I usually end up saying, I agree. Yes, that must be very terrifying. Yes, it must be very terrifying to see that child die because of treatments. Yes, but I don't know what diagnosis that is. And you're saying yes, yes, because they are coming to this conversation thinking you're going to oppose them. So I think you need to find a common ground, build on it, and then try to put forward your point of view is what I would say. But again, Joanna, any other thoughts with it?
No, I think you've covered it adequately. Thank you, Dr. Spandana.
Thank you, Joanna.
There is a question by Smriti. Breaking bad news and the prognosis actually leads to treatment abandonment. How do we counsel parents to opt for treatment? But I wonder, how else would you treat without actually telling them? But yeah, Dr. Spandana, what do you have to say to this? There have been cases perhaps where breaking the bad news and prognosis has led to treatment abandonment. I wonder if it is actually at the pace at which the news has been delivered. And whether it's...
Go ahead. Sorry, Joanna. Sorry.
No, I'm done. Yeah. I wonder about that, whether it's the pace, and I wonder how, what has your experience been of of
So
treatment?
I would say there are two factors, right? Like whenever the communication did not work well, I think there are two factors. One is the one who is giving the information, the other is the one who is receiving the information. And it did happen to me. I was involved in these conversations. This family came from a tribal setting, like 600 kilometers away from Hyderabad when I was practicing. And it's a girl who is like 12, 13 years with a Ewing sarcoma or osteosarcoma. Sorry, I don't remember, but it's in the shoulder. And see, this is what Georgina, I was about to talk about. And the child has to undergo amputation. And when this was offered to the family that this is part of it, they said if a girl child receives amputation, she's never going to get married. And what is the point of taking treatments if she is just going to sit at home, right? Or sometimes they say things like, with all these treatments, fertility will be affected. What is the point of giving a girl child treatment if she's never going to bear a child? So things like that. So I don't think, like, I have had like multiple conversations with these families, but it has always been gentle, never an argument. I was upset. It makes me very, very angry. And I have behaved professionally in these situations, and they have left the hospital. And I'm sure these children have died over a period of time, right? So there are some situations where there's nothing we can do. And in India, we don't have child protection services or any such thing that makes sure that this child receives the treatment. That is part one. Number two, the only thing in our control is there something that we have done in breaking the bad news and providing the prognosis, which is causing them to abandon the treatment? And I've seen this happen too. Like, I've worked with many, many doctors, and some of them communicate in such a way that families find that not taking treatment might be a better option because the doctor thinks they're providing honest information, right? So as much as I would like to say there is nothing more you can do, I would always say, check, is it something that we are doing? And as Joanna has said, have we provided a warning shot? Do they understand like what has been their experience before in their family? They might have had like 3 or 4 people with cancer dying, right? And they would start with, no, we don't want treatment. So how about like presenting evidence? Would that help? How about making them talk to other family members who are willing to talk, and they are giving treatments to their children? So I think there are other ways to try and target that. But again, it needs your patience and a lot of investment of your time and energy. Joanna, please, thoughts? Okay. Yeah. So I think we are at the end of the time. We have crossed the time. Vinila has very gently, I know it's quite late in India. Thank you all for your time and attention. And questions are what keep us going. So thank you so much for that. Joanna, any closing thoughts?
No, just an apology that we've overshot the time. And thank you. I can still see 38 of you still here. And so thank you for bearing with us.
Yes, thank you.
Yeah.
I see there is a post-test link.
Yeah.
Yeah.
There's
Vinila,
a
please go
post-test
ahead.
link. Thank you. Thank you so much. I know with all the limitations, Zoena ma'am, Spandana ma'am, like you took the session so well, and a lot of interaction I could see in the chat, like reading over everything. And as Joanna madam mentioned, still we have 38 participants who stayed back and very patiently listening to this session. Thank you to each one of you. I just have a small housekeeping announcement, like because in view of International Palliative Care Conference next weekend, which is on 13th, 14th, and 15th of February. So our next session will not happen on 13th, and it will be happening only on 20th February. So like regularly, I'll be sending the weekly reminders and one day before reminders on 19th, sorry, on 16th and 20th again. So please requesting all of you to kindly fill your post-test and also share your valuable feedback, which will help us improve further sessions. Thank you so much. And I also take this opportunity on behalf of Hyderabad Center for Palliative Care for keeping this session on the top, both to Spandana ma'am and Joanna ma'am. Thank you very much for agreeing and being with us as always. Thank you.
Thanks, Vinila. Have a good night, everyone.
Thank you, everyone.